So in this video, let us see the 7 common mistakes of flap planning. Now these are the common mistakes which I used to make, I still make. Yours might be different. So please mention about the mistakes you make in the flap planning in the comment section so that others might be benefited because of it and even I'll be benefited because of it. So let's move on to the mistakes of flap planning. Now, first of all, we have to plan any flap in reverse. The first and most important thing is the important anatomical landmarks are to be marked, and they are to be marked in a proper anatomical position. Now, many times we miss marking the bony landmarks, we miss marking the septum between which the axial vessel is going to course, and the position of the extremity is not marked as it should be. It is not kept as it should be. One of the most important and common examples of this is the posterior interosseous artery flap. Now it is typically described that the PIA flap should be marked, should be elevated with the extremity, with the hand in prone position on the chest of the patient. So very commonly what happens is that if we are not able to do the markings in this position, the axis of the septum might be deviated a bit than what it originally is. So we need to do the markings with the hand in pronation and then go ahead with the flap harvest. So this was about marking of the important anatomical landmarks. It should be marked. It should be the first step in any planning. Now, the second common mistake is that we don't consider the thickness of the skin. So we make a template, we mark the template. The template is basically whatever piece of cloth we are using. So it is not as thick as the thickness of the skin. So our flap is invariably planned short. So we need to take the thickness of the particular area into consideration. Now, if the skin thickness is excessive, then again what happens is more amount of tissue is required at the pivot point, and if that is not taken into consideration, our flap invariably falls short. So that is the importance of skin thickness and pivot point. More the thickness, larger the or longer the flap, and pivot point must be planned accordingly. Again, when we consider skin thickness, in excessively thick skinned individuals or when our flaps are going to be excessively thick, there is always a need for delay, especially in cases of fasciocutaneous flaps. So in this case, again, if we are considering a delay, our flap should be planned a bit larger than what is necessary, because after the delay the flap tends to contract a bit, the skin edges need to be freshened again, and then it is also likely that our flap might fall short. So if we are contemplating a delay, we again need to plan our flap a bit larger than what is required. Now coming to the next mistake is not considering the pliability of the skin. Now pliability of the skin varies in different individuals, especially in cases of trauma, contusions, underlying hematomas. The pliability of the skin and subcutaneous tissue is altered, and if the pliability is less, we need a longer flap, because obviously since the pliability is less, it is not comfortably going to turn around and cover the defect. So we need to be very careful regarding assessing the pliability of the skin. Now pliability is also different over different areas. If we see the scalp, it has got galea, and galea aponeurotica is a fairly thick tissue, and the pliability of that tissue is substantially less as compared to our conventional fasciocutaneous flaps which we perform over the upper and lower extremities. So typically over the scalp we need to plan larger flaps as compared to those over upper or lower extremities. So pliability over different anatomical areas based on gender, based on the trauma or contusions or hematomas in the underlying tissue, and based on the anatomical properties of that area must always be considered. Now, not fixing the base, I believe of all the mistakes, this is the commonest mistake. First of all, we need to have a template. Then the base should be fixed. If we don't fix the base and plan our sort of planning in reverse and do our planning in reverse without fixing the face, our flap is invariably going to fall short. So we need to fix the base and then plan in reverse. This is one of the very common mistakes. We feel that we are fixing the base, but somehow our fingers tend to move a bit, and our flap invariably falls short. Then this typical mistake, I think, happens with some amount of experience. We get overconfident. We don't take templates. We don't mark our flaps beforehand, and that invariably leads to failure. So this is the important step. This is the hallmark of plastic surgeons, and we should always use a template. We should always mark our flaps before we commit to the final incision. So this, I think, maybe 2 3 years down the line after doing flaps, we feel that our markings are appropriate, adequate, and then they tend to fall short, and we end up taking back cuts or extension cuts. So templates are a must, and markings should be made. There should be no multiple markings. It causes confusion. Just clean the area again, make fresh markings. It hardly takes a minute or so, and then proceed with the flap harvest. Over concern for dog ear. This also is one of the concerning factors, because especially in the initial phases, what we feel that the dog ear is going to be excessively large, and we tend to narrow the base of our flaps. So over concern of dog ear should always be a big no. Our main concern is coverage of the defect in a safe and effective manner. Dog ears can be always tackled at a later date. They can be excised. More commonly, they tend to settle with time. They tend to settle with pressure garments and crepe bandages, especially over the scalp. Dog ears tend to be very large and very conspicuous, especially in the early post-operative period. But they do tend to settle very well in due course of time. So, over concern of dog ear should not be a big concern for us. They tend to settle with time. Safety of the flap, length to breadth ratio of our flap, inclusion of the fascia in our flap, these are the concerns which we should have over dog ear. Now, perforator not marked. Now, with newer technology, we all have Dopplers at our disposal. So, it is always better to mark a perforator near the base of the flap. We have our handheld Doppler, so it is very easy to mark perforators these days. Marking of the perforator gives us a lot of freedom while designing the flaps. We can always use this perforator to perform a perforator plus flaps, so it gives more amount of mobility to the flap, less I would say our concern in the post-operative period is less, because we are sure of a known vascular supply at the base of the flap. Now, if we don't have a Doppler with us, or if we haven't marked a Doppler, a perforator in the base of the flap, it is always better that the base should be near the joints, because the periarticular plexuses are significant all across the body. As a general rule, we have a good periarticular vasculature. So it is always safer to base our flaps maybe around somewhere between 5 to 10 centimeters near the joints. Obviously, if possible, depending upon the requirement of the defect. So this is always to be considered while planning a flap. And I think these were the common mistakes which I used to do while planning of flaps, and the outcomes, my outcomes and success rates have significantly improved by incorporating all these things in the flap planning. Now, again, at the cost of being repetitive, if you are making some of the other mistakes which are not mentioned here, I would like to hear about them. Please make a remark, pass on a comment in the comment section. Thank you.